Okay, now these are the therapeutic strategies with the drug classes. First of all, if the patient is with focal epilepsy, experiencing simple partial, complex partial, with or without generalized secondary generalization, okay, then you have to go with the choice of lamotrigine, levetiracetam, topiramate. If it does not work, if seizures persist or adverse effects of the drugs are there, then you have to shift towards the carbamazepine, lacosamide, pregabalin, zonisamide. Now, if seizure persists or adverse effects are still there, then you have to shift towards the divalproex, gabapentin, oxcarbazepine, phenytoin, tigabine. And then, if again the symptoms persist, then you have to go to the vagal stimulator. In elderly patients for focal epilepsy, lamotrigine is the drug of choice. Next, if the seizures persist, the drug of choice will become gabapentin. If again it does not work, then carbamazepine, and then at the last vagal stimulator. For primarily generalized epilepsy, if they are absent, then divalproex, lamotrigine. If it does not work, then ethosuximide, and then you have to go with these. For myoclonic, divalproex and levetiracetam. If it does not work, then lamotrigine, topiramate, and then benzodiazepine. For tonic-clonic, lamotrigine, levetiracetam, topiramate. If it does not work, dilproex, zonisamide, and if it doesn't work, then you have to switch towards the vagal stimulator. For status epilepticus, benzodiazepine, fosphenytoin. If it does not work, then barbiturates. Epilepsy syndrome, benign Rolandic, you have to go with gabapentin, lamotrigine. If it does not work, then carbamazepine, levetiracetam, topiramate, and then divalproex and oxcarbazepine. For infantile spasm, West syndrome, corticotropin, vigabatrin, then benzodiazepine, divalproex, topiramate, and then last lamotrigine and zonisamide. For Lennox Gastaut, divalproex, lamotrigine, topiramate. If seizure persists, then levetiracetam, vigabatrin, zonisamide. Again, if persists, benzodiazepine, felbate, and that last vagal stimulator. So this was the indication. Now, anti-seizure medications FDA has approved. It is pharmacokinetics. You can see fosphenytoin has high, pyrampanel has high, phenytoin has high, primidone has high protein binding, tigabin has high, valproic acid high. Then you can see half-life. See, these are exceeding 24 hours. Ethosuximide, felbamate, lamotrigine, phenobarbital is the most, and primidone is also like phenobarbital. Active metabolite, carbamazepine has CBZ, fosphenytoin has phenytoin, and primidone has phenobarbital, same half-life. Okay, now major elimination is liver, but these are kidney, felbamate, gabapentin, and this is hydrolysis, levetiracetam. Then pregabalin is kidney, and vigabatrin is kidney. Drug interactions, because they are going through liver and they are being metabolized, these all have drug interaction except gabapentin, lacosamide, levetiracetam, pregabalin. These don't have. Now, the adverse effects commonly seen are nausea, vomiting, sedation, ataxia, rash, hyponatremia. You have to remember this. Weight gain or weight loss, teratogenicity, contraindicated in pregnancy, osteoporosis.